Dr. John Zugazagoitia to talk about, are we ready for neoadjuvant therapy in EGFR or better consolidation?
Okay, introduction, and thank you, Delvis, and all the organizers as well for inviting me. So in the next session, I will be speaking about the role of neoadjuvant EGFR TKIs for EGFR mutant disease, where we are currently in the clinic, what are the future perspectives, and how can we potentially improve outcomes using novel combinations. This is my conflict of interest. And this is the outline that I will follow. I'll start with a brief introduction. Then I will review the clinical data with neoadjuvant EGFR TKIs for resectable disease. And then I will discuss about consolidation maintenance osimertinib for unresectable EGFR mutant disease, and to finalize with some conclusions. So, of course, everyone here in this audience, I think we are aware of the transformative benefit of PD-1 axis blockade given as neoadjuvant therapy for EGFR and ALK wild-type population. And this has somehow shifted the field to use more and more neoadjuvant therapies for non-small cell lung cancer. We know also that these patients with EGFR mutant tumors were basically excluded from most of these trials. So if we are considering neoadjuvant therapies in these patients, we need to use different approaches. We also know, and we have heard before by Marga, also the transformative benefit of osimertinib and EGFR third-generation inhibitors in early-stage disease. Basically, osimertinib can impact the whole spectrum of EGFR mutant disease, from early stage, locally advanced to advanced disease as well. And the question here is, can we further improve this if we incorporate osimertinib or other EGFR TKIs as part of the perioperative or neoadjuvant strategy? So for that, let's review first the clinical data that we have for resectable disease. So the very first randomized clinical trial that was performed using EGFR TKIs in the neoadjuvant setting was the emerging CTON phase 2 randomized study. As you know, this was conducted mostly in China. Patients here with EGFR mutant disease, stage 3A and 2, all resectable disease, were randomized to receive either erlotinib or platinum-based chemotherapy, as you know. And this trial was pretty revealing because it showed that despite erlotinib being able to produce numerically higher response rates at the radiological level, when we're looking into the pathology, actually these responses were not very good in quality in terms of pathologic complete responses. Actually, only 10% of the patients were achieving major pathologic response, and there was no single patient achieving complete tumor eradication in this study. As you can see, the trial was essentially negative for the primary endpoint, as you can see here. This increase in radiologic response was capable to produce an increase also in disease-free survival, but as we were not seeing complete pathologic responses, this was not really translating into a shift into overall survival, and the trial was essentially negative. So initial thoughts on this data were, okay, maybe we are using a first-generation EGFR TKI. We can potentially improve this with more potent drugs, such as osimertinib or third-generation drugs. Or maybe the duration of treatment that we were giving in the trial was perhaps not long enough to produce pathologic responses. In this study, I think erlotinib was given for 1 or 2 cycles. Well, the truth is that we have now at least 2 small studies, but very comparable studies using osimertinib in the neoadjuvant setting. One was conducted, basically, this was a multi-center study conducted in North America, led by the group of San Francisco, and the other, the NORA trial, recently published as well, conducted in Asia. All have around 30 patients, single arm, but the results are very confirming, I think. And as you can see, again, even using osimertinib, more potent, best drug that we have right now, as you can see, major pathologic response in about 15% of the patients, and we don't achieve pathologic complete response in a single patient in any of these studies. And again, as you can see here as well, there are radiologic responses, some of them are pretty profound responses at the radiological level, but when you look into the tumor, actually the residual mass that is being resected is mostly occupied by viable tumors. So these drugs by themselves are not capable to produce complete responses. And of course, this is in a stark contrast to what PD-1 axis blockade can do as neoadjuvant therapy in EGFR wild-type disease. This is a recent meta-analysis pulling together all the data that we have. And basically, PD-1 axis blockade in combination with chemo increases pathologic complete responses up to 10-fold almost. And this is in very stark contrast to single-agent EGFR TKIs in EGFR mutant disease. And why is this happening? So, well, I have two interpretations, or two hypotheses, let's say. The first one is that you probably need to engage the immune system, or at least engage a potent anti-tumor immune response if you want to achieve complete tumor eradication. Unless we are able to do that in EGFR mutant disease, I'm not sure if we will be able to see complete tumor regression in this disease. So the immune system is really very important to eradicate all the residual tumor. And the second hypothesis is actually related to drug-tolerant persister cells. So probably in a tumor, in an EGFR mutant tumor, there are cells that are very sensitive, exquisitely sensitive to EGFR TKIs, but there are others that are, let's say, less dependent on EGFR blockade, and these cells are able to survive therapy and produce this drug-tolerant cell persistence and residual disease. And actually, we have heard about a keynote lecture almost entirely dedicated to cell persistence by an absolute leading expert in the field. So I think this is pretty revealing on how important this is to further improve outcomes in EGFR mutant disease and other oncogene-driven tumors. Actually, I believe that understanding drug-tolerant persister cells is actually probably the next frontier in precision oncology. It's very important. I'm highlighting here this review. There is not much that we know about the molecular mechanisms that drive drug persistence. I'm not going to improve what Pasi Yanni told us before, but basically this is just to remind you that this is very different from acquired resistance, which is basically driven by increased and sustained proliferation. Drug persistence is a totally different thing. We don't understand this very well, but at least in this review article, they are proposing, let's say, these 4 hallmarks, and it's just to highlight that this is very different from acquired resistance. These cells are able to adapt transcriptionally. They have phenotypic adaptation. They are able to modulate the immune microenvironment and evade the immune system, probably by mechanisms that are different from PD-1 axis. And also they have this genomic instability and error-prone DNA duplication that enables them to survive under treatment. So out of these different mechanisms, I'm just highlighting one that has been at least reproduced by 2 independent groups, one actually by Pasi Yanni, again sitting here. They first described this JAP signaling as being responsible potentially for drug persistence. This is data from a patient, and they had this cancer cell mechanistic paper describing the whole pathway. And this was actually reproduced again by another group by the University of California, again seeing that in patients, actually, these are patients from the neoadjuvant study, there was increased JAP nuclear staining in post-treatment samples. And at least in preclinical models, if you are able to block this JAP-TET pathway, tumors, you are capable to delay or to prevent resistance. Of course, one obvious question is, can we improve complete pathologic responses by using combinations that we know are more effective now in the advanced disease? Of course, platinum-based chemotherapy in combination with osimertinib and also amivantamab in combination with lazertinib has profound impact in PFS. But I just want to highlight here that if you analyze the data in detail, the impact here in PFS is mostly driven by an increase in duration of responses. We are making patients that respond longer, and this is why the PFS curve is shifting. Actually, the numbers in terms of response rate or complete response rates are not very different. when giving a combination. So I'm not sure if these particular combinations will be able to produce a significant increase in complete pathologic response in the neoadjuvant setting, but of course, we have to do the studies and see whether this can improve outcomes or not. The NeoAdaura study is ongoing, as you know. There are others that will be incorporated also to the clinical trial armamentarium. And finally, in the next session, I'm just going to review clinical data on consolidation maintenance EGFR TKIs after chemoradiotherapy in unresectable EGFR mutant non-small cell lung cancer. Well, very known data from the Laura trial, very solid benefit in terms of disease control and progression-free survival when osimertinib is given after chemoradiotherapy. This is practice-changing data, very solid data. So consolidation maintenance is clearly a standard of care in these patients. I just wanted to highlight also that look at how the patients in the control arm behave with chemoradiotherapy. Actually, half of them are progressing in 5 months, and 80% of the population is progressing within a year. And to me, at least, some question that arises here as well is how much chemoradiotherapy are these patients need, or do these patients need to receive? And also to the question of, in the adjuvant setting, how much is chemotherapy actually impacting to these patients? This is a provocative question that we can maybe leave for the debate. Also, some reminders in toxicity here. We're going to see a significant proportion of pulmonary infiltrates in these patients, 50% radiation pneumonitis in the experimental arm. Most of these are related to radiation, but some of them can also be related to osimertinib. 8% pneumonitis is a number that we have to keep in mind, not much, but not less. So we have to keep an eye on these toxicities as well. And, well, this is the proportion of patients that actually need to discontinue therapy, 10% in the experimental arm. And these data have been pretty much reproduced by another third-generation EGFR TKI, aumolertinib. This was a trial done in Asia, basically very comparable results, and they set up, again, the standard of using third-generation TKIs after chemoradiotherapy in unresectable disease. And I think these two studies end up the debate about whether we have to use or not PD-1 axis inhibition after chemoradiotherapy. The answer is no. So basically, this is actually data from the Pacific trial, a sub-analysis from the Pacific trial that showed basically no benefit from durvalumab. And together with the data that we have on the Laura study, I think the debate is over here. So some messages to take home. Well, the first one is that in resectable or potentially resectable disease, single-agent neoadjuvant EGFR TKIs cannot be recommended. Surgery followed by chemotherapy and adjuvant osimertinib is the standard of care and has to be prioritized. If preoperative therapy is being considered, because we are in a multidisciplinary team, and well, we have a particular case that the surgeons actually promotes us to use neoadjuvant therapies, in the absence of conclusive evidence, I would favor the use of chemotherapy in combination with osimertinib, of course, in agreement with the rest of the team, and we have a clinical trial that will provide final answers in this regard. In unresectable stage 3 disease, consolidation maintenance osimertinib is the standard of care. Of course, all these treatment decisions needs to be made by a multidisciplinary team. And finally, understanding molecular mechanisms driving drug-tolerant persistent cells, as we have been discussing before, I think is the next challenge to further improve outcomes, not only EGFR mutant disease, but also in other oncogene-driven lung tumors. Thank you very much.